Welcome everybody to the August Grand Rounds of 2021. This month we have Dr. Kara Yezzi with us. She's going to be talking about the multidisciplinary approach for treatment and maximizing community integration or reintegration after TBI. Dr. Yezzi graduated with a bachelor's degree in health science at the University of Central Florida, and with her Doctor of Physical Therapy at the University of North Florida. She's board certified in neurologic physical therapy and served on the neurologic residency faculty at Kessler for 5 years. She's certified in Rock City Boxing, LSVT Big, and is an APTA credentialed clinical instructor. She practices at St. Luke's University Health Network and sees patients with stroke, brain injury, Parkinson's disease, multiple sclerosis, balance, and vestibular disorders. Just as a housekeeping, make sure that you answer the email when you get the notification from My eLearning that to take your quiz and the course evaluation. And if you are watching this from a recorded perspective, make sure you're doing that inside My eLearning to gain credit, or contact me and I will help you with that. So without further ado, I will transfer over to Dr. Yezzi.
Thank you, Steve, for that wonderful introduction. So we're going to be able to kind of skip through a couple of these slides. As Steve had mentioned, we're going to be going over an evidence-based review for treatment interventions and use of multidisciplinary approach in order to maximize community reintegration in the TBI population. So now I'm going to go through all these slides. It talks about the credits, designation statements, the learning objectives, which I know you guys had already received. And then I was going to go over a little bit about getting to know me, but Steve did a great job introducing me. So I'm just going to kind of skip ahead to the end where I did join St. Luke's in 2020. I originally started at our Hillcrest Center in Phillipsburg, New Jersey, and now I am currently full-time at our Clinton, New Jersey location, helping my facility director over there grow a neuro program there. I also developed a NCS study group program in order to aid mentorship and test review for each upcoming exam year. So we're going to get started on some TBI facts. In 2019, there were 61,000 TBI-related deaths. Firearms related to suicide was unfortunately the most common cause of these deaths to date. What do you guys think might be the most leading cause of TBI-related hospitalizations in the United States? If you were thinking falls, you're correct. We're going to talk about this slide, talking about the 5-year outcomes of persons with TBI. These statistics are very interesting. We're going to talk about this for a little bit, and please don't hesitate to ask questions moving forward. 22% of these patients had died, 22% had stayed the same, and 26% had shown improvement. Overall, though, what I really want to talk about is 30% of them became worse. That's huge. It's the largest amount, and they're becoming worse. So what I'd like to know is what caused these patients to get worse? Could it be a rehospitalization or multiple rehospitalizations? Maybe social isolation from not being able to integrate into their society and being stuck at home or being confined more into a long-term care facility or into hospitals. The inability to drive or work, that's a lot of times a huge part that could also relate to isolation. What about maybe increased caregiver reliance? You know, everybody wants independence. People want to be independent. And what can we do to try to gain that? It could also be a learned helplessness. Sometimes, our family members, when they're taking care of their loved ones, they start to help too much. And when they start to help too much, it creates this learned helplessness in regards to their ability to function and maximize their gains. Because their family member goes, I'll just do it for you, don't worry about it. But then they start to lose that independence again. What about a severity of the TBI? So of note, all this information had come from the TBI Model Systems National Database. This data refers to people from 16 years or older, and they did have some form of an inpatient rehab stay. So from a severity of the TBI standpoint, they could really be ranging anywhere from mild TBI to a severe TBI. Another question that you can ask yourself is some of these reports of becoming worse because they actually are gaining improved awareness into their deficits? There was another study by Corrigan et al. That had talked about post outcomes from TBI. And this was interesting because the survivors who were 30 to 59 years old had measured the greatest dissatisfaction and depression out of all the age groups, including the ones that were 80 years or older. So that's huge. Why are these people who are from 30 to 59 years old recording the poorest global outcomes? Let's think about it. What did we do between the ages of 30 to 59? That's really where we're living our lives. So people might be going to school. Maybe they were already enrolled in school and now they can't go back to pursuing the degree that they wanted to. What about dating or having a partner or a family? Maybe they are a family and now they're not able to participate in those roles that they always enjoy doing with their family. Social interaction, being able to hang out with their friends, being able to hang out and travel or travel locally or travel throughout the world, being able to also integrate and learn new tasks and new skills, being able to be a part of a work field. All of those things are very important, especially in those age groups. So now I ask, what else can we do as healthcare professionals? My role as a physical therapist, I can help educate patients on their progress and provide positive feedback. Providing resources is another big way that I can try to help these patients get what is it that you want to get back to? What is your main goal? Being able to also work on balance. So talking about those falls. Falls is one of the largest reintegrations for hospitalizations. How can I help reduce those falls? Now, other members of the healthcare field, so doctors, nurses, case managers, what else can we do to try to be proactive? Maybe looking at somebody who might be a case of polypharmacy, and maybe that's what's causing an increased amount of falls. Is there something that we can do? From a case manager, nurse perspective, as well as doctor perspective, what about resources that we can do? Going back to that article, from those ages of 30 to 59 years old, it kind of makes me ask that question, are there community resources out there? And maybe we're just not using them enough, because maybe we have a big role in helping bring this percentage down. So before I get ahead of myself, let's review some basic anatomy and functions of the human brain. So from a frontal lobe, this is going to be looking at that filter. So you're going to really see the personality or impulse control, decision-making skills. Executive functioning is really key in these areas, in addition to speech. These patients, if they have an injury to their brain, they could be affected, their ability to communicate their basic needs to you if they come to your office when you're working with them, as well as their family. Their pre and primary motor areas are also in this area, so being mindful that there might be some form of a weakness going on too. The parietal lobe has controls our speech comprehension, identifying of objects, spatial recognition, as well as facial recognition. The temporal lobe is going to look a little bit more at the hearing, memory, and music. The occipital lobe is also going to look a little bit more at that vision areas of the brain. And then we have the cerebellum, so the balance center and coordination. We're going to review a little further and talk about the differences between TBI. So there's a traumatic brain injury, which is caused by that external force. So a fall, a car accident, a strike or blow to the head, or an acquired brain injury. This is going to be resulted by an internal or metabolic injury. Some of these things can be from an anoxic injury. So let's say somebody has a cardiac arrest and now they've had a long period of losing oxygen to the brain. Any type of intracranial surgery, so a tumor removal or intracranial hemorrhage, so that extra bleeding into the brain, or also toxic exposures. A lot of times these toxic exposures are related to substance abuse. Both of these types of brain injuries can result in a temporary or permanent impairment as well as vary from partial to total levels of disability. I really like this definition from the Brain Injury Association of America, where they talk about the brain injury being an impairment of cognitive abilities or physical functioning. It can also result in the disturbance of behavioral or emotional functioning. So, not all brain injuries look alike. What are things that we as healthcare professionals need to do in order to help modify our interactions? This can also help start the conversation. If you're working with a patient and they kind of seem off, or you suspect that something may or may not be going on, ask the question, complete that screening. Maybe this person had a history of a tumor removal 6 years ago and somehow it got missed in the medical chart. Or maybe they actually have a history of having a couple of concussions 10 years ago, but never thought it was important to share with anybody. We're going to now talk about some classification systems of TBI that are used for less than 1 year post-onset to assess the cognitive and memory function. So this is the Rancho scale. We're going to briefly talk about Rancho levels 1 through 3, where 1 is going to be that no response. So these are those patients who are in a coma state, completely unresponsive to external stimuli. A generalized response is going to have that inconsistent or non-purposeful responses. They're also going to present with that unresponsive wakefulness syndrome. The localized response, which is Rancho level 3, is that minimally conscious state. So these patients are going to present with very inconsistent responses, but they will be purposeful. A lot of times, in order to qualify for an inpatient rehab stay, the patients will have to be in that minimally conscious state. So here's some treatment considerations. Looking at ventilator management or trach management, DVT prophylaxis, passive range of motion, contracture management, turning, positioning, being able to help reduce these pressure sores. Surgical procedures, these patients are still going to be very medically fragile in these stages. Also performing a coma recovery scale, which is a scale that's utilized to look at the auditory, visual, motor, comprehension, communication skills that we typically see in order to reintegrate out of a minimally conscious state. So these are typically done multiple times a day by multiple disciplines in order to see, has this person emerged from this minimally conscious state? And that's measuring the accuracy and the consistency of their ability to interact with the environment. Be mindful in these stages that these patients will really require a quiet and controlled environment. So even if there's no noise going on in the room, what about the lights? Is there a buzzing noise? Is the light flickering? All of those things can really also impact someone's ability to be overstimulated. Also documenting different responses that you see in the time of day, because different levels of arousal, these patients will have very inconsistent sleep-wake cycles, so arousal is going to be pretty key here. Family education is also very important in this stage. These patients, these families are going to be very, very nervous and upset. They're going to have lots and lots of questions because they just watched a huge major life change happen to their loved one. And it's also going to be a major change for them as well. So especially they're going to be highly relying on the guidance of the doctors, neurologists, case managers, and social workers for the next steps. Because of the lack of communication from the patients in these stages, you also want to be mindful of any type of signs or symptoms of any type of visible distress or objective signs of possible sympathetic storming. Sympathetic storming is also defined as paroxysmal autonomic instability with dystonia. This is classified by diaphoresis, tachycardia, hypertension. It's a lot of times from a noxious stimuli that may be present. So maybe from a catheter, or if the sheets are ruffled and it's causing extra pressure onto this patient. This is a medical emergency, so if you ever notice any of those signs, please make sure that you alert it to your medical team promptly. So the next stages are some of my favorite stages. These are the Rancho levels 4 through 6. Rancho level 4 is that confused, agitated state. They're going to be unable to participate in any type of structured task. They're not going to really have much short-term or long-term recall. The confused, inappropriate stage, so level 5, you'll start to notice some simple command following only, but they will still be distracted, highly distracted, and they will demonstrate inappropriate object use or inappropriate responses to things that you're asking them. The confused appropriate state is Rancho level 6, where you'll notice simple command following, but they'll still have a lot of difficulty with any type of abstract or complex tasks. They can demonstrate some carryover, but typically will still require a lot of different cues, and it can fluctuate based on the different times of day. Memory and cognitive impairments will still be present, so being able to make sure that orientation and schedule is a key. These patients in this Rancho level 6 stage will also present with an appropriate object use or response. Okay, something else to be of note, which we'll talk about a little bit more in some future slides, if you're noticing anything that might be inappropriate. So remember, these patients are totally relearning social integration, orientation, they're kind of re-exploring their whole bodies. So it's not uncommon where they may say things that are very inappropriate, or they might try to touch or reach or kind of make gestures that are also very inappropriate. So it's very important to make sure that, one, you keep yourself in a safe spot, but then also making sure that you let them know that whatever they're doing is inappropriate. A lot of times, you know, if you're working with someone, they start to kind of lean over and try to give you a kiss because you remind them, or they think they're your spouse. So kind of, you know, it's very appropriate to say, hey, what are you doing? You know, I'm your physical therapist. I'm not your wife. To help bring in that reorientation to that patient. Sometimes you also may have to mix, you know, having a male or a female to work with that patient due to some of those inappropriate responses, at least initially on. So now we're going to go over a little bit more treatment considerations. We're going to divide them out a little bit to specific Rancho levels, and then we'll kind of talk a little bit more generally. So in that confused, agitated state, you're going to be able to provide the closed-ended choices. Because if you just ask them, hey, what do you want to work on today? Or what is your goal for therapy? Or what is your goal so I can help you because you're trying to do your assessment because you're meeting this patient for the first time. They may not be able to kind of answer that question. And they might just shrug their shoulders and say, I don't know. So provide that choice. Do you want to do this or that? Is your goal A or B? And that can help provide a better means of finding out what your patient really wants and what their goal is. Developing a schedule is huge in this stage, and really try to refrain from changing it until you notice that it's still not conducive for the patient. I personally find that developing a schedule that works is probably one of the most difficult things, because once you find something that works, then maybe the arousal state might change, and then you have to change and modify that schedule all over again. Also be mindful to try to communicate in brief, clear, and concise phrases. Don't do that. Step here, because if sometimes talking too much, it can create that overwhelming sense and overstimulating sense due to that lack of comprehension and that delay of comprehension, because it might take your patient 20 to 30 seconds just to comprehend what you're saying. The confused and inappropriate state, level 5, will require some assistance for an activity setup, but once it's set up, they should be able to interact and engage with it. Also try to provide lots of orientation, whether it's actively or passively, and be mindful to make sure to schedule frequent rest breaks. The confused appropriate stage, so Rancho level 6, try to encourage initiation and completion of tasks. That repetition is going to be really key here. Also, in educating on the importance and rationale to participate in a structured activity, because remember, because of some of these cognitive impairments and some of the fluctuations in orientation and arousal, they may not understand the context of what you're doing. Also being mindful of what you're asking the patient to do. If you have them reaching to touch cones, are they really going to understand the purpose of that? But maybe if they're a carpenter or a mechanic and you have them work on fine motor, holding screws, nuts, and bolts and trying to organize them into a toolbox, maybe they'll actually have a little bit more buy-in because it's a little bit more salient to them. Be mindful that these patients will still have very limited insight into their deficits, so being able to create a safe environment, but being able to also point out some of those insights and deficits that they may have. So safety is going to be really key here for all of these stages. Use of restraints such as enclosure beds or mitts may also be needed in these stages too. They also might have sitters or spotters, so try to wean them when appropriate, but remember that some of these things will definitely be needed in order to maximize safety for both your patient as well as for yourself. Try to be mindful to watch your tone of voice and limit visitors in these stages because it can become very overstimulating as well as a safety issue. Looking at behavior management, which we're going to get to in a little bit, our passive orientation will be key. Being able to modify and adjust the stimuli. A lot of the times in these stages, you're working in a very quiet and controlled environment. Once they can consistently perform in that quiet and controlled environment, taking them out to a little bit more of a busier environment where people may be walking around and to try to test that level of distractibility. Things like bringing in their favorite types of music or hobbies, pictures of family members, or things that are familiar and favorable are also really beneficial in these stages to help especially develop a rapport, as well as try to help motivate your patient to participate. Be mindful too that these patients can be discharged at these stages, and they might even plateau at some of these stages. So educating not only just yourself, but also educating the family members on how to keep the home environment safe is going to be crucial. Things like locking up sharp objects or alcohol or medicines, hiding keys, confirming the level of supervision or use of cameras, educating the families on this behavior management and communication styles. That's also very huge because the families might get frustrated and they try to keep reasoning with their family member and then they get frustrated and then it can cause a downward spiral. Also tracking sleep. A lot of studies have shown that less sleep can also be related to a decreased cognitive recovery in these patients. Rancho levels 7 and 8, we have our automatic and appropriate stage and then the purposeful appropriate stage. Both are going to be pretty oriented, but they can still be pretty forgetful. In stage 7, they can be able to independently perform in structured settings, but they're still going to have that lack of insight and some judgment. In the purposeful appropriate stage, so level 8, that safety and judgment will be a little bit better in a controlled environment. However, if they're either under stress or in an unfamiliar situation, they still may be a little bit more inconsistent. They're also going to present with some difficulties with some abstract reasoning. Don't forget that in these stages, even though they're higher functioning, that routine and schedule that was originally in place is still very crucial. So other treatment considerations, being able to increase those task demands and reduce rest breaks. Also working on divided attention and working memory. Looking at that frustration tolerance and patient and family education. A lot of times be patient in these stages. Give that patient that autonomy and independence, especially if it's safe to do so. Other things to consider. How much did your patient actually hear you? You can try strategies like teaching back with a scenario or asking them to repeat are some two beneficial ways to help make sure, did they actually understand what I was saying? Or did they actually hear what I was saying, or were they too distracted? Was that environment that I just had that patient in successful for that learning and understanding or their performance? Sometimes either therapy gyms or doctor's offices can be so busy and so crowded, or they might have multiple family members in the room where there's so many other things going on that you're not actually sure that if they're understanding or paying attention to what you might be talking about. Being able to monitor that frustration tolerance and that fatigue level of the patients and being able to look for signs and symptoms of that. The two most important questions to really ask yourself is, what does your patient want or need? And what does the caregiver want or need? Making sure that, are these even aligned? And if they're not, what can we do to try to help make them aligned, as well as making sure that both the caregiver as well as the patient are being taken care of? Some other things to consider are redirecting the patient rather than trying to challenge them. or being able to reinforce those positive behaviors and model those positive behaviors. Structuring the environment and the setting will really also help set that patient up for success. You can even schedule different types of rest breaks. Also try to avoid that overstimulating behavior, and just remember to really try to provide and offer choices. The number one thing, though, if you don't mind me saying, is also looking at seeking professional help sooner rather than later. Because a lot of times, not even just for the patient, but for the caregiver as well. They've been through a huge lifestyle change, and it's going to take a toll on both the patient as well as their caregivers. The other thing I'd like to touch base on is looking at, are we challenging these patients enough? Or sometimes, are we challenging them too much? Because what can this lead to if we start to challenge our patients too much and put too much demands on too soon? Different signs of escalation. So these patients might be pacing, or did they start from looking away or looking around the room and now they have this fixed gaze on you and kind of staring you down? Or are they looking away because they don't even want to pay any attention to you whatsoever and they're looking for a way out? Are they restless or rocking? Do they start to wander, moving around, whether they're in a wheelchair, or do they start to kind of just walk around the room? Their vocal tone. Do they go from kind of casually talking to you to then starting getting louder and louder and louder? Or does they start to get that increased pace where they start to talk faster and faster? Other types of perseverations. Do they keep just holding on to something and now they're fixated on it? Being mindful that these are some silent signs of a risk for escalation or agitation. So some tips if you start to notice this happening, because it can and will happen. Really, I find it to be successful to say, wait, what's wrong? Is there something I can help you with? Because sometimes they'll tell you, or if they can't communicate it with you, they'll try to demonstrate, like, why haven't they called? And maybe it's because the family member was just in the room and now you're left alone with the patient and they're wondering where their family member just went. And they're thinking that you're the person who just hid their family member and that you're hiding them. So now they're going to take it out on you. So being able to ask that question early to try to find out how can you try to help them. Also try to remove a trigger. A lot of times bathroom is going to be the biggest trigger. They have to go to the bathroom, but they may not be able to figure out how to go, or they may not be able to get themselves there safely. Allow mobility. A lot of times these patients may be sitting for prolonged periods of the time. So if it is safe to do so, try to be able to allow them to explore the environment, whether they're in a hospital setting or a home setting, just making sure that we're keeping it safe. Always try to be mindful to stay calm and speak calmly, because these patients will start to feed off of your energy if you start to kind of talk louder with them, or you start to sound a little bit more unstable, unsteady or unconfident, then they might just start to take advantage of that, and it'll kind of cause them to increase a little bit more. Your safety is also number one, so trying to make sure that you are closest to the exit. Try to be mindful not to put yourself in the back corner of the room, because then that could put you into an unsafe situation, especially if these patients become combative or violent. If it's also safe to do so, try to alert staff. A lot of times hospital networks will have a protocol in place for this already, but from a patient or family education standpoint, you could always teach the family members to have either a safe word or being able to keep family members on a speed dial if something like this were to happen. Things to try not to do: really try not to touch the patient, and especially without their consent. And sometimes this can be really difficult because people tend to try to offer an assuring hand touch and kind of say, it'll be okay. But that might be a great way where they're going to grab your hand and try to bite you. Or they might just grab your hand and try to break your arm. Please try not to restrain the patient unless it's absolutely necessary to do so, for safety for either yourself or others. Because once again, it's a great way for you to risk yourself getting hit or punched, or also hurting the individual as well. Try to be mindful also throughout all of this, they might be yelling and screaming directed at you, but try not to yell back or try to reason with them. Just try to keep repeating what it is you'd like them to try to do, and then try to do some of those strategies that we talked about removing some of the stimuli or getting help if needed. So let's practice. Patient LR suffered an anoxic brain injury and was admitted to an acute inpatient rehab center. The therapist walks into the room to find LR in an enclosure bed along with a sitter, rolling around the enclosure bed, going into the tall kneel, and then transitioning back to supine, and then continuing to roll. When you talk to the spotter, they say, "They haven't stopped for 2 hours." When the therapist said hello, LR made eye contact, but did not respond or interact with the therapist. So what Rancho level could LR be? If you were thinking Rancho level number 4, you're correct. What are some possible interventions for LR? So in this scenario, we really set up that environment and kept it safe. All those things that we just talked about earlier, we let LR move around. So we had the ability to have a small controlled therapy gym where we set up mats and just let her roll and explore her environment. And then as soon as we kind of noted to calm down, we saw that she would relax and actually be able to either sustain a conversation or improve a little bit more of the arousal and attention. Once we were able to start to do that, we noticed we also tried to present some passive orientation and also train the staff that if, let them stay, for this case, we let them stay in that enclosure bed because it was able to keep them, that the rolling was their way of self-soothing. So by keeping her in an enclosure bed, it let her be able to kind of calm herself down. So then that way we didn't risk that type of agitation. Throughout the hospital stay, which was approximately 2.5 months, LR began tolerating structured tasks at limited quantities, could express basic needs, and use objects appropriately, as well as follow simple commands with external cues. You also find LR has a very supportive family. Now what Rancho level is LR? She would be Rancho level 6. What other interventions could be appropriate in these stages? So LR was a parent and they did have children. They were in the working field. So we started to introduce meaningful roles. We had LR helping out at meal times, helping the nursing staff collect trays. They also helped kind of direct some of the conversations during mealtime. We also gave them a role where they could sit by the front of the brain injury unit where they had to practice their social interaction and engagement, being able to appropriately say hi to people, as well as then kind of asking how they might be able to be helped. And they kind of became our greeter for the unit. Let's also practice again. GY is a teenager who suffered a TBI from a skateboarding accident with substance abuse. You also see them in the inpatient rehab hospital for your PT evaluation. Upon arrival, GY points at you, laughs at you, tells you to go away, all while still laughing. What should you do next? Well, say, "Hey, that's inappropriate. Why are you laughing? Why should I go away?" And kind of bring out that social awareness. What Rancho level do you think GY could be? Well, it's kind of unsure based on the information that I currently gave you. But if I said that GY was able to complete a simple complex task, what do you think? I'd say about Rancho level 6. So good thinking, guys. GY fluctuated in activity tolerance and agitation throughout the hospital stay. GY had significant hemiparesis, significantly delayed motor planning and processing, as well as delayed auditory comprehension. Word finding deficits were also pretty present. What do you think some treatment interventions for GY could be? So reintroduction of social norms was really crucial for GY. Increasing his task demands, setting goals for task persistence, and increasing challenges of environments were also things that we really focused on in therapy. We had also recommended a discharge to a community reentry program in order to help really provide that life skills that GY would need in order to maintain and improve his ability to participate in his environment, especially being a teenager and returning back to school. I am pleased to say that both of these patients had discharged home successfully. I actually still stay in touch with GY to this day, and they are currently studying very hard to become a physical therapist, and I just found out they graduated from their program with a 4.0. So it really can happen. Now, a study by Degraba et al., they looked at the efficacy of an interdisciplinary intensive outpatient program for 1,400 U.S. service members who had suffered a mild TBI. They looked at the following outcome measures, and their treatment team included nurses, family therapists, neuropsychologists, neurologists, and their therapy team. This program had followed a 6 to 8 hour per day for 4 weeks, focusing on both individual tasks as well as group activities in order to help provide that social interaction as well as their individual needs. What were their results? They saw statistically significant improvements in all 7 assessments. Of note, St. Luke's at the Hillcrest Center currently has an intensive neuro day program at the focusing on PT, OT, and speech, where they get for 3 hours a day for 4 days a week. Kreutzer et al. Also looked at, this was a Brain Injury Alliance a BIA USA study that looked at 186 adults with mild to severe brain injuries and looked at their return to work for up to 4 years. The results, 35% of these individuals were employed 1 year after their injury. 37% were employed after 2 years, and 42% after 3 to 4 years. By the 3rd year follow-up, so a total of 7 years from injury, 34% of these participants were stable employed, which is defined as being employed for 3 years following the injury. 27% were unstably employed, which is defined as 1 to 2 years post-injury, and 39% were unemployed since the date of their injury. Their big takeaway factor, the ability to drive a vehicle, was strongly linked to a stable employment. So how can we help? As we kind of been talking about throughout this presentation, we follow these patients on their journey to being able to try to improve their ability to participate in their environment and return back to their life roles. So what can we as healthcare professionals do to really help? Maybe St. Luke's can create a division-wide database so that way we can store resources. Also, as healthcare professionals, if we start to ask the right questions, it can help us utilize resources appropriately and effectively. So we're going to talk about some resources throughout the Pennsylvania and New Jersey regions. We have the Brain Injury Alliance of Pennsylvania, where they offer virtual support groups. They have an annual conference in October, where it's designed for all healthcare professionals, caregivers, survivors, and family members, which is located in Lancaster, Pennsylvania this year. I attached the information for both the contact information for the hotline as well as their website. They do also offer brainline.org, which is a subsection of the BIA-PA, which provides support to those who are suffering from PTSD as well as survivors of TBI. The Brain Injury Alliance of New Jersey offers a lot of different resources as well. So they also do currently provide virtual support groups as well as continuing education. So they have 2 different conferences. One is which the Human Service Conference in March, which is a topic specific. So last year they did a take on first responders with TBI. Then they also have a healthcare professionals conference in May, which varies on the different types of topics. So be on the lookout for those. I believe the Human Services Conference is free, when then the Healthcare Professionals Conference you have to pay for. They do also have a helpline and as well as their website, so I put all the information on there as well. Their helpline and their live chat is accessible from Monday through Friday from 9 to 5. And their website, they actually just redid it, and it's amazing. It's very user-friendly, very easy to navigate, and they're also very responsive. I had sent out an email, and within 24 hours, I already had 2 different responses to help answer the 3 questions that I had for them. We're also going to talk a little bit about their CARES program. Their CARES program stands for Connections, Assistance, Resources, Education, and Support. So this program sets up not only just patients, but caregivers as well, with specific social workers to help advocate for their special needs throughout the state of New Jersey. For example, if a patient is trying to get therapy services, but is unable to drive or figure out how to set up their services, their case manager will be able to help facilitate the appropriate services needed. Or let's say a caregiver is overwhelmed in managing their loved one, or they're lacking specific resources to help provide the care in their home. They will be able to assist in organizing the appropriate support for that caregiver. They do also offer a week-long camp, which is called Camp Trek, and it focuses on socialization and recreation for those surviving from a TBI, but they must be 18 years or older, as well as be a resident of New Jersey. When I'm speaking with the directors of BIA and J, they were also expressing a great need in the Warren and Hunterdon counties as far as resources for their survivors. So St. Luke's is definitely going to start to get on board. The Brain Injury Alliance of America, their helpline information is also listed, as well as their website. They also offer virtual support groups, so please feel free to kind of look through that, and then they can also help funnel down and show you the statewide resources. I would also like to touch base on some other programs that unfortunately I've been noticing a decreased number in, and these are the community reentry programs. I've been able to have experience being a part of these community reentry programs and really see firsthand how they can be beneficial for these survivors. You know, we kind of noticed, we talked about those Rancho scales, and it's now this patient has now left the hospital setting, which is a completely controlled environment. Now they're home, and then we expect them to completely reintegrate themselves back into society as if nothing's wrong with very limited resources. So now what? So these community reentry programs were able to challenge these patients and these survivors to go back to those life roles that they had, whether they're a student, whether they were an accountant or a teacher, professor, all different life-specific tasks, but they were able to do it in a controlled way. It utilized a team of speech therapists, occupational therapists, neuropsychologists, and physical therapists. It really helped answer the question of, can these patients function in real life? In my experience, it's been so beneficial. So in my opinion, it's a pretty underutilized resource, and maybe it's something that we can start to look at doing a little bit better. So are there any questions from the audience?
So there was a question by Lizel earlier. She was wondering how long the initial outcome period was in your earlier study that you mentioned. And Lizel, I don't know if you have a microphone, if you'd like to ask this question for some clarity, that would be helpful.
So both of them were 5 years from time of injury. I don't know if
so that was the outcome period, right?
Yes, yeah. Both were 5-year outcomes.
I'm curious what they were comparing that to.
I agree. It was actually from the TBI model systems. It was very kind of unclear. I think they were just extrapolating the data from all of the model system sites in the nation that were looking at, you know, the satisfaction, dissatisfaction. And then the article from Corrigan et al., I'd have to double check to see what they were comparing it to, but it was looking at like their quality of life scales. But I can get back to you on more of that details. I could even send you the article if you'd like.
Sure.
It was really interesting. Any other questions?
Lizel, do you want to ask the other question you asked on the chat?
I was, as you were sharing about the emotional and behavioral disturbances, and even I started thinking more about it as far as the communication and the dynamic with the family. I'd be very curious, as someone who's worked in some similar settings, to know how that would impact those 5-year outcomes, because I know, and you've seen the same, that a lot of times how the family is managing that patient, how long are they willing to help? How long are they willing to keep up those, or schedules and strategies and things like that? And I think when it just becomes, okay, I've got 2 kids that are growing and my husband that I need to care for, and what's going to give? I'm going to just do dressing for him instead of him letting him do it for himself, because it takes 3 times as long and I have to do X, Y, and Z. And I don't think there's a lot of great resources as far as patients and families being able to have more long-term support in these kind of situations that would ultimately lead to better outcomes.
I very much agree, and that's also something we're, hoping to establish more of that relationship with BIA&J to see if there are more resources that we can utilize. Because exactly, I mean, I've seen patients, their spouses divorce them shortly after the injury, so now they don't even have, they went from having a family and a spouse to try to help them, but now they're completely alone, and now what? Because they need that help. So thank you, Liesl, so much, because that definitely is going to be something that we can try to look at. How can we get some more of those resources? Because it is so true. The spouses and the families, we're in healthcare, so we kind of get it a little bit more, but not every family member is equipped to being able to take on that caregiver role, which is why we need to try to get the resources for psych services sooner, not just for patients, but also for their caregivers. And every time we do interact with that family member or that patient, also kind of doing a check-in with that caregiver as well to see if there's anything else that they may need sooner rather than later to try to help reduce some of those frustrations that could lead to those poorer outcomes. Thank you, Liesl. That was a great point. Any other questions? Well, you guys were a great audience. Thank you so much. If you do have any questions, you can always send me an email. It's at kara.yezzi@sluhn.org. Thank you.